Welcome to today's video lecture. Today, we're going to delve into a fascinating topic, neonatal respiratory distress syndrome. Before we start, don't forget to check out our website madeformedical.com for hundreds of more videos like this at the end of this video. The link is in the description. In this session, we will delve into the intricacies of neonatal respiratory distress syndrome, including its definition, etiology, pathophysiology, clinical presentation, diagnostic approaches, and management strategies. By the end of this lecture, you will have a comprehensive understanding of neonatal respiratory distress syndrome and its impact on patient care. So, let's begin. Let's start with what is neonatal respiratory distress syndrome. Neonatal respiratory distress syndrome, also known as hyaline membrane disease, is a respiratory condition that occurs primarily in premature infants. It is characterized by insufficient production of a substance called surfactant, which helps to keep the air sacs, alveoli, in the lungs open during breathing. The common causes of neonatal respiratory distress syndrome include: the most common cause of NRDS is premature birth. Infants born before 37 weeks of gestation have a higher risk of developing NRDS due to the immaturity of their lungs. Surfactant production, a vital substance that helps keep the air sacs in the lungs open, is often inadequate in premature babies. Surfactant deficiency. Insufficient production or deficiency of surfactant is a significant cause of NRDS. Surfactant is produced by specialized cells in the lungs and helps reduce surface tension, preventing the collapse of the air sacs during exhalation. In premature infants, the surfactant production may not be fully developed, leading to respiratory difficulties. Maternal risk factors include maternal diabetes. Infants born to mothers with poorly controlled diabetes have a higher risk of developing NRDS. The exact mechanism is not fully understood, but it is believed that high blood sugar levels in the mother can affect surfactant production in the fetus, leading to respiratory complications after birth. Maternal infection. Certain maternal infections, such as chorioamnionitis, infection of the placental tissues, or Group B streptococcus, GBS, infection, can increase the risk of NRDS in newborns. These infections can cause inflammation and damage to the fetal lungs, affecting surfactant production and lung development. Multiple gestation. Twins, triplets, or higher-order multiples have an increased risk of NRDS. In multiple gestations, the risk can be attributed to factors such as prematurity, lower birth weights, and the potential for growth restriction, all of which contribute to immature lung development and surfactant deficiency. The signs and symptoms of neonatal respiratory distress syndrome typically manifest shortly after birth or within the first few hours. These include rapid and labored breathing, characterized by retractions, pulling in of the chest wall, grunting sounds during exhalation, cyanosis, bluish discoloration of the skin, lips, or nails, poor feeding or lack of interest in feeding, lethargy or decreased activity levels. The pathophysiology of neonatal respiratory distress syndrome involves a cascade of events resulting from surfactant deficiency. Without adequate surfactant, the alveoli have high surface tension, causing them to collapse during exhalation. This collapse leads to atelectasis, reduced lung compliance, and impaired gas exchange. Additionally, the collapsed alveoli cause a ventilation-perfusion mismatch, where air is unable to reach the collapsed areas, resulting in areas of the lungs receiving inadequate ventilation. This can further contribute to hypoxemia, low blood oxygen levels, and hypercapnia, high blood carbon dioxide levels, in affected infants. Diagnosing neonatal respiratory distress syndrome involves a combination of clinical evaluation, medical history, and diagnostic tests to assess the respiratory status of the newborn. Physical examination. Healthcare providers will assess the baby's breathing pattern, oxygen saturation levels, and signs of respiratory distress such as retractions and nasal flaring. A chest X-ray can reveal characteristic findings such as a ground glass appearance, indicating atelectasis and reduced lung expansion. It helps to assess the severity and extent of lung involvement. Blood gas analysis. Blood samples may be taken to measure oxygen and carbon dioxide levels, as well as pH levels, to evaluate respiratory function and the severity of respiratory distress. Managing neonatal respiratory distress syndrome focuses on providing supportive care and assisting the infant's respiratory function until their lungs mature and produce adequate surfactant. Treatment strategies may include the following: respiratory support. Continuous positive airway pressure, CPAP. This involves delivering a continuous flow of air or oxygen through the baby's nostrils or mouth, helping to keep the airways open and improve lung function. Mechanical ventilation. In severe cases, the baby may require intubation and mechanical ventilation to provide controlled breathing support. Surfactant replacement therapy. Exogenous surfactant. In some cases, synthetic surfactant can be administered directly into the baby's lungs through a breathing tube. This helps to improve lung compliance and reduce the risk of complications. In conclusion, neonatal respiratory distress syndrome is a respiratory condition primarily affecting premature infants due to inadequate surfactant production. Early diagnosis and appropriate management are crucial in supporting the baby's respiratory function and optimizing outcomes. For more videos like this, please subscribe to our YouTube channel and visit our website madeformedical.com. Link is in the description. Thank you.